All right, it is 1 o'clock and we are going live. So thank you everyone for joining our ninth Black Males Mental Health and Wellbeing Support Group. We're really excited to have you join us. We're excited to have our panelists. We have, obviously, as you see, these lovely faces. We have Tyson Jackson. We have Dr. Jonas Lee. We have Dr. Alvin Thomas. And Dr. Logan Edwards. And so they will be giving a little bit more about their backgrounds. But first, I'm your host, Aaron Perry. I'm the president of the Rebalanced Life Wellness Association. And we're really excited to be broadcasting live from the barbershop. We're in Madison's largest Black barbershop, which is where we have our Men's Health and Education Center. So really thrilled to be able to come and bring this important session from the barbershop. With that said, let me have our gentlemen introduce themselves. We're going to start with Dr. Lee, and then we'll work our way around. I think you're muted, Dr. Lee.
Sorry about that.
That's all right.
I am a family doctor with the University of Wisconsin Department of Family Medicine and Community Health.
Excellent, excellent. And then Dr. Edwards.
I am an assistant professor of health education at the University of Wisconsin-Whitewater. I'm also a health education program coordinator and a lecturer of health behavior and health equity at UW-Madison.
Excellent, excellent. Dr. Thomas.
Assistant professor in the School of Human Ecology at the Department of Human Development and Family Studies, clinically trained, working specifically with Black families, fathers, and father engagement.
Excellent. And then our special guest today, Mr. Tyson Jackson.
Hi, Tyson Jackson, University of Wisconsin, in the Collaborative Center for Health Equity, as well as the All of Us research program, really looking at community research with a real lens in health equity. So targeted research efforts within the university.
Excellent, excellent. Well, thank you all for joining us today. We're going to focus today on the discussion on really looking at obviously, Dr. Lee is going to give us an overview of COVID-19. Let's keep our friends and family and supporters who are down in the South and Southwest as this is making a major comeback in those areas. But Dr. Lee is going to give an overview of COVID-19 and what we're seeing in our area. But before that happens, I want to make sure we thank the sponsors, SSM Health, the Wisconsin Partnership Program, and definitely a big thank you to our supporters over at the All of Us program. So with that said, Dr. Lee, if you can give us an overview of what's happening from your lens.
So locally in Dane County in Wisconsin, we haven't seen a huge change yet. But the numbers are creeping up. So for the state of Wisconsin, one of the things that we look at to know how we're doing is what is the average number of new positive cases that come in every day. And the state follows a weekly average. And we peaked out at about almost 500 new cases a day at our peak. And then we really made a dramatic improvement in that. And that those numbers fell to around 300 new cases a day. And unfortunately, the latest data we have from just the last couple of days, that number has been creeping up. And the last one that I can see is like 370 new cases as the weekly average. And so I think, unfortunately, we are mirroring what much of the rest of the country is doing, is we are getting increased rates as people are venturing out and about, as the lockdown restrictions have been lifted in a lot of places. And as you've seen in the news, there are places where, like in Texas, where they're reinstituting the lockdown. Here in Dane County, we're going backwards to a different level of lockdown. But it's variable because each state is different. And so unfortunately, it looks like there might be a rebound as people are kind of re-engaging and getting out of their homes. The flip side, in terms of the information that's out there, I don't think a lot has really changed in terms of recommendations and guidelines. The one thing I guess I would put in a plug for is The things that we seem to know and recommend are still the same. Probably the biggest one still that has not changed is people should still be keeping physical distance from other people. And we should be wearing masks when we're outside of our home. And the research seems to indicate really so that we're protecting other people from ourselves. There's enough research coming out that suggests that lots of people have no symptoms. The percentages vary depending on what study you look at. And lots of people have minimal or very few symptoms. They don't think they're really sick. And so the benefit of wearing a mask is so we don't pass it to someone else. Its protection for you is probably less, but it's still really, really valuable if we're going to keep this in check. And the thought is, we could really slow this down tremendously if everyone would participate. So those recommendations in terms of what you can do to protect the community hasn't changed, and what you do to protect yourself really hasn't changed either.
Okay, interesting. Any of the panelists have any questions for Dr. Lee?
Yeah, Dr. Lee, I'll raise a question. Just for all of us to discuss, and also for the audience to hear, so that we can just educate ourselves a bit better on some of these practices that will help keep us all safe. Again, I'm looking at this from the perspective of behavioral health. So I dig into the nitty-gritty observation of behavior, and that gets very, very specific when you're talking about human behavior. And there's quite a few behaviors that we can all practice. And I always tell people in conversations, or that ask anyway, it's almost like pick a handful and practice those behaviors. There's 10 or 15 things we can do to protect ourselves. And I say, pick a handful. And I do agree with you that I think social distancing is the most important. So with that said, is if you're able to maintain 6 to 10 feet distance away from anybody that you're around in public, is there need to wear a mask?
That's a great question. The research that is out there clearly shows that the farther you are away from someone, the chance that you'll spread it decreases tremendously. I think it's almost like exponential how far that falls off. So theoretically, you could. It gets complicated by things like if people cough, or if people are exercising and they're breathing more heavily. Yeah. There was an anecdotal thing, but it actually turned out to be significant, of a choir, I think it was in Seattle area, who they infected all of themselves going to choir practice, just because the vocalization and singing actually spread it a little bit further than that distance. And so that's kind of ends up being the caveat. If people are coughing, sneezing, they can actually spread that further than that 6 foot distance. So I think, again, if you're in those situations where where it's not a household, in the grand scheme of things, I think it's safe. It theoretically makes sense that if you're beyond that distance, really the risk is really small. If you're outside and that same thing applies, I agree, the risk is really, really, really small. But there are just a couple of things that we can really do that really make the biggest difference. And the biggest difference probably are mask wearing and keeping our physical distance from people probably make the biggest difference from what I understand of the research. Yeah.
I agree, because, unfortunately, the wearing of the mask has been something that's turned political.
Yeah. And it needn't be.
Yeah, and I think it's important to just discuss that aspect of it that says, wear a mask, not wear a mask, distance or not distance. I really do think that a good rule of thumb is to again pick a handful of those behaviors and practice all of those, just to make sure that your mind is at peace when it comes to knowing if you are going to contract this or even be a silent spreader of this. And I've equated it to almost like all of the precautions that are in place in a motor vehicle. You have a motor vehicle that has an airbag, you put your seatbelt on, and you have a motor vehicle that's got good brakes, hopefully. You want all three of those things. You don't want to just focus on one of them. You want to wear your seatbelt, make sure the brakes are good, and that you have an airbag, just so that you are assuring yourself that you're going to be safe and protected if something bad were to happen. And I think that equates with this behavior and this health issue as well.
No, great. And I think it's great advice.
Excellent.
On the ones that work.
Dr. Lee, I kind of have a two-parter. So you mentioned that you're seeing increased cases, but the cases seem to be less severe. Would you say that overall they've been less severe? Because you're saying that symptoms are pretty obsolete right now, not too many symptoms.
Well, so one of the things that happened that always makes this really difficult is we needed to have more testing of the general population. to really know how much coronavirus was out there. And one of the problems we had is just from doing the math of it, we really didn't know what the denominator was of what we were dealing with. And so the estimations of how sick people get or how many people die were really unclear because we just didn't know how many people were mildly ill or asymptomatic. So it looks as if, and it just ends up being a mathematical thing, more and more people have gotten tested, and they really opened up and increased how much testing was available to people. So at the beginning, we were only testing people who were symptomatic. And now if you want to test, you can pretty much get a test. And so it will, I think, falsely look like I shouldn't say falsely, it will look like the percentages are lower of people who become really ill with it. However, overall, if people are still becoming ill, the more people we test, yes, we're going to find more positives. And we might find more people who are mildly sick. But I don't know that like the disease itself has necessarily changed. I'm not sure if that was what you're necessarily getting at. But you know, the percentages are what they are, and I don't think those will change. So for example, like if the death rate happens to be 1% or 2%, my impression is that's going to be stable. And it really becomes an issue of how many people get sick. That's going to drive the mortality rate for this.
Excellent. Thank you for that. Dr. Thomas, do you have a question?
No question.
Okay, sounds good. So we're going to go ahead and move into our next our presenter for today, Mr. Tyson Jackson. The reason we invited Tyson is because we know that ultimately a vaccination is coming. First and foremost, we want to make sure that we are doing everything that we can do so that when the vaccination arrives, we are here for it. And which is case in point, while we have Dr. Lee here going over and dispelling some of the, the false information that's out in the community. And this is not a time for this to get political. Unfortunately, it is. But we know a vaccination is in stages of development. I know it sounds like Africa is already doing some things, but we wanted to have Mr. Jackson come on because there's still a concern about the African American community participating in research. There is that concern that's still in our community, and what we want to do more than anything is start this conversation early so that as we get closer and closer to the vaccinations that we can hopefully dispel some of the fears. And so Mr. Jackson, the floor is yours.
So thank you. So I guess I'll start with, so not only has the nation been dealing with the pandemic, but also the deaths of some of our African American brothers across the country. We've all been drawn into this important work of helping our nation address the consequences of racism. So is it in clinical research. When we look at especially community health research, we are very well versed to the health disparities that are within our communities and the impact of racism on health. We see it every day. We're not the only ones that see it. Of course, healthcare providers see it. When you look at prisons, you see the impact of racism on our community. Those are just a couple examples. And so when I have these conversations a lot, why would I participate in research? Conspiracies, the government's out to get you. And all of that distrust is warranted, right? There's a history there. People are aware of it. It's not, and I never go and say, you don't have a right to, you have a right to feel however you feel towards research and towards the country or towards an institution like the university for not doing their part with, this racial inequity and a lot of times adding to it. But, the fact always remains that we have been suppressed and we have these huge discrepancies when it comes to many, many health concerns, illnesses, and diseases. And so we have this kind of issue where we have research ongoing, and everybody that's participating in research happens to be Caucasian, largely Caucasian men. And then we go into, oh, I'm sorry. That's my dog. Here, let me let him outside quick.
Okay. So while Tyson is busy dealing with the puppy, you know, when we, as Tyson was talking, one of the things that Dr. Edwards, Dr. Thomas, and even Dr. Lee, if you guys can offer some suggestions just in case someone is struggling with, you know, the comprehension of research and maybe reading about it and having those genuine fears. You know, if you guys can and you know jump in and interrupt Tyson, if I can sure I can speak for him, it's okay. We just want to make sure that we're bringing all sides of this clinical part and offering people any information that they can. So Tyson, I just mentioned to our panelists that if they have any feedback based on what you're saying, so they may interrupt you periodically with their questions. So, and you're muted.
Sorry about that.
That's all right.
Oh, what I was saying is, so we have research going, right? Breakthroughs are going to happen. Vaccines are going to happen. New medicine is going to happen. Research is always going to happen, right? There's lots of money put into research every year by the government. And, you know, we're missing in that equation all of the time. And so we have this thing where we have the people that are the most healthy in our community continuing to get the health advancements in medication, prescription drugs, things like that, because the drugs that they're creating and they're trialing are usually on Caucasian America. And so you have this thing where you already have the kind of this supremacy here, and then it just continues to kind of distance himself because we haven't been able to get involved. And so there's a history behind that, right? And so you look at the history of research, the unethical research. You know, a lot of African-American folks will bring up Tuskegee and the unethical research that was done. You have individuals that they're giving this disease and not allowing them to seek treatment. They're ending up dying because they assumed that because they were Black, the disease didn't affect them to the same extent that it affected white people. And so they were just used as essentially guinea pigs for this this drug and this trial. Then you have Henrietta Lacks that people are very familiar with, and the use of her cells continuously without the family being notified. And then really you're looking at, you know, chemotherapy and the treatment of cancer the way it is largely due to her. And you have people that, again, felt left behind and slighted in research. And, you know, there's a number of cases like this in prisons with Native American communities, even where researchers were traveling out of the country to Latin American countries to do research just to try to get cures for certain things, all unethical, all terrifying communities. And so there's that history, and then that's what we know, right? Because that's what's talked about. That's what's, you know, understood by the community. Once I have this sour taste, you know, you're not, you know, fool me once, shame on you, fool me twice, shame on me, that kind of deal. And so then people are stubborn and stuck, and rightfully so. Why would I trust someone? Why would I trust the government? Why would I trust this white person? Because researchers are largely Caucasian, as it's not very diverse currently. And so you have this mixed bag of every single reason to distrust. And so I often like to educate folks on how much it's grown. So what's the evolution been like over time? And so after a lot of the research that had been done that you hear about in the 1980s, they came up with this thing called the Belmont Report. This report really instituted protections for the participant, instituted the IRBs, or the review boards for research, instituted things like that, so that people, like consent, making sure people understand consent, that you're telling the entire, that there's no small writing that says something that could put you at risk, right? That the research has the participants' best interests in mind, and that the consent is informed. Lots of things like that. Review boards. So they have review boards, the IRBs, that are put in place for every single research project. You have to, they question everything along those guidelines to make sure that it's safe for the community, right? And so now if a researcher were to try to do something that was unethical, or give you a drug that they knew might give you some sort of side effect or illness, or even kill you, they'd be held completely liable. And that's what was missing in the history, right? They were doing these things and getting off, completely free, unscathed. And so now in research, it's a completely different landscape from that sense, in terms of the protection of the participants. And then moving beyond the protection of the participants, now you have the issue of getting people of color to actually get involved in the research, right? And so now you have African Americans that don't trust, or other people of color that don't trust, and you have largely white researchers. And so now you have largely white researchers, African Americans that don't trust, and no necessarily like mandated of making sure that you have representation in your research, right? And so now research can be done. It might be really, really hard for me to get someone of color to participate in my research. And so I'm gonna go ahead and get it done the easiest way possible. And that's by getting the people that already are aware. So that's your academia, your people that are in the hospitals that might really be looking for something because of whatever their situation is to help cure. And so you get into a position where it's really the people that have access already that are being pulled on to be participants and get the research done, which again comes back down to that being white America. And then so you wonder, like, why are African American people not participating? And it's not necessarily the fact that they're all just saying no, or that we're saying no to research, but what it ends up being is that researchers just aren't confident or don't want to do the work to get the African American folks to participate, right? Because now it seems like that's extra work, because they already don't trust me, they already don't want to get involved. And so now you have this thing where, once again, you're spreading that gap, right? And that's really a fault of, I think, just the way that we haven't diversified our research practitioners. So the people that are practicing research yet, we haven't diversified the way that we educate folks about research opportunities, about health opportunities. And we haven't done a good job of creating community with the institutions or local institutions where the research is happening. And UW's no different than any other institution, right? And then so we look at what can we do now at this point? So now we're at this juncture where we have a community that's potentially has this mistrust, that doesn't, might not even be understanding or learning about the opportunities that are available. And then you have research that's gonna just keep on going no matter what. And so we're kind of at a crossroads now. And so it's, I think, up to folks like myself and some of the people on the panel that are doing a lot of this work in the community and with people of colors to do our best to educate folks and to try to help understand what the important, or how important it is to get involved and to not be left behind. Because as we look at the health disparities and where we are as like an African American community or a Native American community, and we look at projecting it out, if we continue the trend, the gaps that we have are just going to continue to grow. And that's the hard reality of it. And so getting involved is becoming increasingly important for our community. And we look at something like COVID, and we have this longstanding systemic health and social inequities that have put some members of certain race and ethnic groups at higher risk of experiencing severe illness, regardless of age. And we look at, they just put out a report by the CDC and talked about how basically Native individuals and Black individuals are 5 times more likely to have a severe reaction to COVID than their white counterpart. And Latino persons are 4 times more likely to have severe cases of COVID from their white counterpart. And so I always try to encourage folks that if we want, and it's not, you know, it's our communities, right? It's where we go, our churches, you know, things like that, where we congregate, where we trust that we have to help educate too, so that they can help us spread this education and knowledge around to our communities, because you need trusted entities. Right? So if I walk into you know, just a random neighborhood, or people don't really know me, but if there's a community space there that people understand and people know, and then that community space understands the research and trusts the research and can pass along that information, and then have me there to back that up and make sure that they know that we're there to support. Then you can build sort of this trust between the community and start to build this bridge, I think. And, you know, so I tell people, you know, we're kind of, you know, about that crossroads. So it's, you know, we're at this juncture. Would you like for our community to get healthier over time? Like, if you don't have the proper ingredients, right, you can't bake the food correctly. Right, you can't cook your chicken with the proper spices. I equate, you know, cooking to, you know, prescription. If I get sick, I need the right medicine for me. That's tailored to me. Being a biracial person, being a Black person, or being a Latin American person, or being an Asian person, we're not all the same. As much as, you know, we all are human, but genetically there are differences, there are variances, and a lot of that variance is not just where we look at our culture, but it's, you know, years of this kind of epigenetics, so there's traumatic effects of certain things that have happened in our past, right? And so I always, like, for me, you know, I don't necessarily have the science to prove it, but I look at things, so like OB-GYN, right? The practice of OB-GYN was really founded and formed on the bellies and bodies of Black slave women. And then I look at something today where you're torturing, killing, really changing the physical build of a person, and then genetically how those things pass along generation to generation. And you look at infant mortality, things like that. And you say, well, there's one area or one lane here where this could be stemming from, right? These traumatic events in history that change us biologically. And so all that's to say is that if we don't engage and educate ourselves and understand the research, so as COVID goes on, we already see we're at highest risk, 5 times higher risk of dying or having severe reaction to COVID-19. Then the only thing that'll happen going forward is they're going to develop a vaccine, and it's going to be without us. So when they want to put the antibodies in our system with the vaccine to help our bodies learn to fight off the virus, it may or may not actually work effectively for us. And understanding that and I tell people today, prescriptions all the way down to your Tylenol, your ibuprofen. I can take a Tylenol, ibuprofen, it might not do a single thing for me, and I might still feel miserable. And you say, well, why is that? Why isn't my body reacting to that? Well, people like me weren't around when they were actually formulating this drug and developing this drug.
Right. And Tyson, if I can interrupt for a second, first of all, thank you for laying that out for us, because as we're listening, we're making the connection to why things are why we believe and why we feel and why we don't trust. And it all comes together, especially when I've had opportunities to speak with my Black sisters. When we talk with them, and I understand this, many that I've spoken with are very uncomfortable with their kids being vaccinated, extremely uncomfortable. And as we begin to lay this out, it's obviously going to be critical as these vaccinations start to become developed, that we start to have these conversations. And this is why we're doing this now. But I want to give, obviously, the other panelists an opportunity to share, mostly how do we start to have those conversations and safe conversations. So if you guys want to add to that, and then we'll get back to Tyson.
So I think it's a walk and chew bubblegum kind of idea. I hear a lot, and in my clinical training, in my teaching, in the research, I hear a lot of what Tyson has just talked about, or some of what Tyson has just talked about, which is the recognition of the historical mistrust and the foundations upon which that mistrust is built. Sadly, often that is where it stops. So we say, great, there's all this mistrust among African Americans for these systems, and we need to do better. We need African Americans to start trusting the system. Well, that's just not enough. That's like walking up to an abused person and saying, I recognize that you've been abused, but you now need to go in and start trusting your abuser. The systems that you've known to be responsible for it, or representative of it. I think what we need to see, and we're not seeing yet, is a change in institutional policy, in institutional philosophy that first recognizes that pain, and that pain that's at the center of the distrust. It's not the distrust that's the issue. It's what's causing the distrust. It's that memory and that pain that's attached to it. But more so than that, it's taking the responsibility away from those individuals who are feeling or experiencing that, and putting it back on yourself, putting it back on the system. What can we do as doctors? What can we do as clinicians? What can we do as researchers? What can we do as however we represent the system, that can undermine and lessen the impact of, in some cases, built-in supremacy, white supremacy? How can we undermine that in a way that makes these other communities feel comfortable? Because that's what it is at the end of the day. People will go where they feel comfortable. If you walk into a space and it doesn't look like you, it doesn't represent what your community is, it doesn't look like your culture, it doesn't celebrate who you are. You walk down the halls and you see picture, and you're nowhere on there. You walk through, you see the doctors walk by, and not one of them looks like you. That says something about whether you should feel comfortable or not. If I walk into a party today, well, maybe not today because there's no parties, but if I walked into a party and I saw nobody who looked like me, even if they were all Black, nobody's playing Caribbean music, there's no jerk chicken, there's no rice and peas, there's nothing that looks like me, that's my culture, I feel a sense of discomfort. I will be comfortable because they're all Black. But if I walk into a space where there's nobody who looks phenotypically like me, and there's an absence of my culture, I do an about turn. Because it means I will be spending so much of my energy trying to fit in, rather than the party directly catering for my culture and catering for other cultures. And I think that's where we are with the research, that we're talking about the distrust and the mistrust and the history. We're acknowledging it without doing anything substantive. Oh, I shouldn't say anything because I think people are doing some things, but without doing enough that is substantive, and putting that burden on us rather than putting it on the community to do that work. And I've seen some really good work. I know when I visited Madison in 2016, I think we took a trip down to, it might have been Milwaukee. I have no idea where I went. But they had developed these community IRBs, institutional review boards, so that when the Ivory Tower IRB had decided what they decided as far as the research was concerned, they had to then take it to the community IRB before it could be passed. And the community now can say, oh, I see you're asking these things in these ways. You can ask them and get a better, more reliable response if you change the wording to look like that. So you actually get the response that you're looking for if you change the wording, because we understand our people. We understand the community. We understand where they're coming from. You're also going to be able to reach them better if you did it in this way. But like Tyson said, I think a lot of researchers, a lot of clinicians included, are not willing to do that extra work and are not willing to put on par with medical knowledge and book knowledge, not willing to put on par with that community knowledge, cultural knowledge. I think that is also extremely important. And I think that's often missing in that conversation.
Excellent, excellent. Dr. Edwards or Dr. Lee, do you have a response to that?
Tyson, I had a quick question for you. I know that there are different areas and departments within the UW that do have community advisory boards. In fact, I've been listening in on one that deals with Alzheimer's all the time. And so I don't know how well those get advertised in the community, because I think it's really important that people know that there is an advisory board of people who have the same concerns that people have, that the community has, and want to know the answers. And I think unfortunately, maybe it's not supposed to be a secret, but it seems like a little bit of a well-kept secret. Because I think people would be a lot more comfortable knowing that there are people doing that work from the community with exactly that job.
Yeah, and if I may, quickly, I think you're spot on with that. So I mentioned that I'm part of the All of Us program. We have our community advisory board, and for the audience, just so you're aware, what that is so we went out and got members of the community, and I think most community advisory boards, some are built with clinicians, some are built with community leaders, and it really kind of varies, and you try to really have a diverse group. So representation in terms of race and ethnicity, in terms of different sectors within the community. So like your education, your health sector, potentially business sector. And so you get this group that's representative of the community, and it's hopefully representative of the folks that you want to get involved in the research. And then so what you'll do then is you'll meet with them to talk about the project and let them lend their voice to some of the things that you have, help guide some of the community engagement efforts that we're doing to make sure that we're incorporating all of the facets of our community in terms of diversity, versus doing kind of what history has shown, and that's, taking the easy route. And so, community advisory boards are a great piece of a lot of research projects, and probably should be utilized even more in research. And like you mentioned, getting the education out there. So what is it? Can we just, what if someone just wants to get involved in the community advisory board? How do we get a process like that where the community can actually come in and then share their voice with certain projects that are going on with the community? So yeah, thank you for bringing that up.
Tyson, I'll do you one better, and I've seen it happen in some research projects I've been involved in, that I think we have to get to this point where, again, I think it's part of what I was saying earlier about divesting the responsibility from the institution and putting it upon the community. And I think the community advisory board is one way of divesting that responsibility that should be the main responsibility of the institutions and researchers to change that interaction with the community and putting it on community advisory boards. So I'll do you one better and say that I think we have to get to this point where community advisory boards are built into grants. Not only is there financial support for those community advisory boards, but that they remain part of the grant or part of the research project throughout. Because you want to know that after you've started collecting the data, what's happening during that time? How do you interpret that data once you've analyzed it? What kinds of suggestions are you making based on those findings? And I think you need to have the community's voice to filter and distill, to provide body to the structure of the research that you're engaging in. But I think also making it so that the effort, the work that the community is putting into that research is also financially compensated. Because this is really heavy work that people are taking on. And so making sure that's added. So I look forward to the day when CDC and NIMH and others set aside specific parts of the budget just for that as well.
Mm-hmm. Yeah,
Absolutely.
excellent. You know, one of the things we're looking at, they just released this information in the media. The United States has seen a record-breaking 45,300 new confirmed cases of COVID-19 in one day. I'm so glad that we're having this discussion because we have to continue to provide this information, make it available, and each and every one of you guys bring a different talent to make that happen. But I'm glad that we're having this discussion. Also, I know that people can't see, I'm in the barbershop, but I see all these little beautiful Black boys coming in with their fathers, and they all got masks on. And we're really pleased to see that our Black men are definitely, from what I can see here at the barbershop. Now, I've been here for a couple hours now. I've seen about maybe 25, 30 men bring their kids in, and they all have masks. So it's really beautiful to see that. Also, I want to take this time to plug that this nonsense about fathers not taking care of the babies, because come to the barbershop, you'll see it day in and day out. So Dr. Edwards, I didn't know if you wanted to share before we get back to Tyson.
No, I think that the panelists really said it well. I for those who are asking questions about how to get involved in the research process, I would implore everybody to look up community-based participatory research. Study that, read that a little bit, see what that's about, and then engage that process. Reach out to those folks in your communities that are doing the research or that have connections to folks who are doing the research, and say that I want to be on an advisory board. I want to be involved. I want to be a community member who shows my face, who has my experience, and who has my voice, and I can speak for some elements of my community. If you're that interested and think it's important, which it is, I would encourage you to reach out to those folks and do a little reading on community-based participatory research. That's what I feel like we're talking about here. And I do agree with Dr. Thomas that it almost needs to be a mandatory part of the research process. Being culturally competent, being culturally responsive, and engaging the community either through participatory research methods or even more ethnographic, where you have to have researchers insert themselves into the communities and live amongst them and communicate amongst them, congregate amongst them, really learn them from the inside before you just start asking outside questions and looking for outside information that suit your own interests and your demographics interests, but not the community's interests. I just think that maybe needs to be the future, and I can't wait for that day too, where that's just mandatory and that's the norm across all researchers.
Mm-hmm. Excellent. And Tyson, the question obviously came up: how can they get involved in the research? Given obviously COVID-19, there's been a slight pause. What's going on? Can you speak to that a little bit?
For research in general.
Yeah, or even with what we have with All of Us.
All of Us, yeah. So All of Us, this program that I'm working on, is a national program. So you can imagine that when I have to go out and talk to community members about the program, I'm talking about, it's a national program, right? So we have to fight that off. And then, I'm working for the UW, we got to fight that off. And then just research in general, we're really fighting that off, to get people to want to listen and take part. So All of Us is a program designed, it's a biobank. And so essentially we're asking individuals for saliva and urine collection that we'll keep in a data bank. We'll have other information, height, weight, waist measurement. All the information that we get, we provide back. So when we take the saliva, we provide back actually full genome sequencing to individuals if they want. And so you get ancestral information, you get health information based off of your DNA reading. And then we're using urine collection to be able to look at environmental factors in health. So the toxins that or pollutions that you may be subjected to based on where you live. So for instance, I live on the east side of Madison, and just up the street, so there's an airport nearby, but just up the street, which is typical pretty much from wherever you go, that you find a lot of the low income neighborhoods next to multiple highways, next to the airport, next to all these. And so they have all these factors of pollution, right, that go in, and we know pollution contributes to asthma. And then we know that a lot of the folks that are residing in that or those complexes happen to be African-American. And we know that African-Americans struggle the most with asthma and asthma-related deaths. And so you kind of have this big conglomerate of the perfect storm for continuing to impact a community in a negative way in terms of their health. And so we look at information like that to then store and then allow researchers from across the world to use this diverse data set. So we talked about mandating representation, mandating community advisory boards. With this project, all those things are in place. So we're mandated to have at least 40% underrepresentation. And right now we're at like, I think nationally we're closer to like 70% race and ethnic, I think it's about 50% race and ethnic, and then 70% representation in terms of other groups. And so those groups are disability, LGBTQ, rural, low socioeconomic status, race and ethnicity, and then over 65. And so we're looking at all those groups because all of those groups in research are just underrepresented. And so this project is really designed so that, and I'll take COVID for example. So individuals that have participated and gave their biospecimens were able to, in a private manner, so everything's de-identified. They're not going to have like name association with the information, but researchers could then say like, I would like to study, I know diabetes is a big thing with Aaron, I would like to study African-American men with diabetes, and so then they can get this big group. And so that takes out a lot of that initial effort for recruitment. And so it really shaves off and speeds up the ability to create research and medical breakthroughs. But looking at something like COVID, so we're also able to then use it in ways that we might not even have yet, or things we might not even know yet. So as COVID comes up, all of a sudden it's like, well, where can we look to get this information? And so now you have this biobank with, and so you can look, so you can take a time frame. So I think what they're doing is they're taking a snapshot from about December through March, and anybody that had enrolled within that time, looking to see if there's any COVID relation to their work or their blood work and things like that. And then you're able to, it's always like the foundational research, right? And so it's not like people are going to take this information and go off and do certain like trials. It's really just getting the foundation or your hypothesis for what you think may be the cause or effect of some disease, and then building on your research. And so it'll allow folks to come up with these hopefully new treatments and medications for people that are representative of who we are. So medications are specifically geared towards a specific culture or race. Hopefully will be the dream one day. And so that we have, and so if we know from a pharmaceutical standpoint, if we understand that we have a drug that we know for a specific community will work, 95% of the time, that also, in a kind of a backdoor kind of way, will reduce cost of healthcare, insurance, things like that. because now we're not testing all these different prescriptions on individuals when we come in to the doctor. You come to the doctor and say, I'm gonna prescribe you with this. Let me know if you have any side effects, let me see if it works, or if it doesn't. And so we're already kind of doing this crapshoot, I think, when it comes to people that we don't understand a lot, or we don't have a lot of data on. And that just happens to be us.
Excellent. The time is 1:49, so we got about another 50. I love sharing that because this is such a great conversation, and I love the fact that we still got adequate time to get the questions. But more than anything, I wanted to make sure that we took a little bit of time to talk about the vaccinations that are in development, that's currently being developed, and starting to get folks prepared for when that happens. We're just not, given what I'm hearing about this infection and multiple waves of it that's coming through, it may not be a time that we will have to sit back and decide whether or not we're going to participate in that. This sounds like it could potentially be life and death, and I'm hoping that I'm not overstating that. But can we start to share with folks that may be a little afraid, concerned, maybe something that we can start sharing with them to get ready, with what's coming down the pike. So how about Dr. Thomas, and then we'll go to Dr. Edwards and Dr. Lee.
Actually, I want to punt this to Dr. Lee.
Okay. Sounds good.
not to put you on the spot, but Dr. Lee, so when I started thinking about the development of vaccines and the eventual need for vaccinations, and then you pair that with some of what Tyson shared earlier and some of these thoughts about these historical inequities that still exist, some of the histories of distrust that have been well-founded that still exist today. We won't see the institutional change happen by the time the vaccine comes around. But maybe Dr. Lee, from your own practice experience and from your training and from your own experience as a person, what would be, I think maybe what might be necessary is to provide the community with some form of preparation for how to think about and also how to eventually interact with that discussion around a vaccine. There's lots of information about it that's some erroneous, some just far-fetched, some just outright lies, some kind of in between. But what are some suggestions you would have? Let's say a parent is thinking of going in, an African-American man is thinking about going in to get his blood work done or something, to see his doctor, and he knows that he will eventually be asked, do you want to take this vaccine? Let's say the vaccine is finally out. He's told, do you want to take this vaccine? It's currently available. What are some things you would share with that gentleman or that woman about how to make informed decisions around that?
I think my answer to that would be several-fold. I mean, just in terms of my role as a physician,
right.
The things, unfortunately, there isn't a lot of data. And, this may be, I'm afraid I might end up comparing apples to oranges here, but just in general with people who are distrustful of vaccines, unfortunately, there's a lot of data, and actually my selling things without actually answering people's concerns and questions actually doesn't get anywhere. And in some instances, I feel like it actually makes the situation worse. There have been some practices that have a little bit of research behind them in terms of being effective. One of them is just like, it's the standard of care, and it just kind of happens and we barely talk about it. It's like, I recommend this vaccine, and we just, right. It's just part of the process, just like getting your vital signs as you're gonna get the vaccine. That's actually been shown to be effective. And then making a clear recommendation. Well, to take a step back on my end, it is a matter of building trust first and having a good relationship with patients. I think it's probably first and foremost. And then also admitting that there have been like egregious mistakes from the medical community in terms of if the distrust is actually the issue.
Right.
And then specific to vaccines, I mean, vaccines are some of the most well-researched things that we have. And there's a long, long history of like the impact. It's probably, you know, along the lines of a handful of the best things that have happened for human health in the history of mankind. But unfortunately, you know, this is lost on people. I think what's going to make the coronavirus different is I think it is clear, and there's been enough press, that coronavirus clearly is impacting people of color and populations of color. And so I think the idea of the vaccine, hopefully, therefore, will be more palatable because it's really been devastating for people. So I hope it's not too hard of a sell. I'm a little bit anxious only because obviously there's a huge hurry to get the vaccine out as quickly as possible. And as you heard initially, I mean, the time frame that we're thinking was like 12 to 18 months as of like a month or two ago.
Yeah.
On the other hand, like the vaccine process seems to be going faster than that. But one of the things that has always made vaccines, I think even there's so much fear about them that I think the CDC realizes that that has to be that much more safety data.
Yeah.
And I hope that there is enough research prior to the vaccine going out into popular use, that there's enough data. And I think there will be, because they're already trying out vaccine. They're already doing administering vaccines and doing vaccine research at this point in time. But it takes a while to get all the data in order to say it's actually safe. But to take a step back, so the first thing I think is like really working on our relationships, really making a clear recommendation that this is what we think is best. And then from a personal standpoint, like I talk about, for example, for the flu, I talk to patients about, I get flu vaccines. I recommend them for everybody. I recommend them for my family members every year, and to make it a little more personal to them. But again, the coronavirus, the thing that makes coronavirus different too is for all these other vaccines that we have, is for most people, they've barely seen anybody who's had an illness related to those vaccines. And there's strong research that says when that illness is present in the community, the vaccine rates are really high. And when the memory of that illness and how severe and horrible it was starts to wane, then the vaccine uptake is less. Therefore, I think the vaccine uptake is going to be really, really high because people can see the impact of it in their communities, and particularly for communities of color, how rough it's been. So I'm hoping will set us up well for there to be good uptake right now.
Oh, excellent. Yeah. And Tyson, it looks like it's 1:57. I know you're going to have to be leaving us soon. So I'm going to give you an opportunity to kind of, share a little bit more before you have to get out of here.
All right, thank you. I don't have too much more. Just that, things like this, being able to help educate the community. This is what's going to be important, because like Dr. Thomas and Dr. Lee were talking about, a lot of what we alluded to are things that need to happen. Are going to take time in terms of transforming kind of the landscape of research. But in the meantime, I encourage folks, especially our people of color, to really look at just educating yourself. Make the decision that you feel good about, right? You want to be able to trust whatever you're going to get involved in. If you don't trust it, don't get involved. But educate yourself, read up on it, understand the importance and the significance of it. And because if a vaccine is created, and once again, goes through trials that have limited involvement of African Americans, we're selling ourselves short in the end, right? And then we don't know what it's going to look like in the future if this ever comes back, and even harder. We talked a little bit about Africa earlier in the broadcast, and just how their community is responding to it. I think South Africa is a representative of almost like a third of the cases within Africa, and so in partnership with Oxford and in England, they are starting to do vaccine trials. And so, unlike us, the African community, they're looking at it from a resource standpoint. And so as it's really starting to impact the community, and it kind of did in a late stretch, right? So it really impacted the United States, China, and then Africa kind of got the wave a little later. And as people kind of speed to kind of come up with this vaccine, and research, they saw it as a way to help with the community health on the front end before the vaccine, because they might not have the resources to have enough or to purchase enough of the vaccine for the people because of the way that their economy is. And so they're using it, kind of looking at it in a different way and saying, well, if we can get ahead of it and understand it, yes, they are still fearful, but it's important to know what's going on. Is this going to work? Is there, and to be able to have that access to information. Because the one thing they don't want to do is have a vaccine created and then not have enough or not have access to it for their community, right? And so looking at it from a different lens. And so as we look at it here with, a slightly different landscape, and, it would be, the government and all these, research pharmaceutical companies that are going to be eventually doing these human trials, they'd be very remiss if they didn't mandate that we had participation from the groups of color that are from this. And so I expect that they will, but then it comes down to the people to actually get involved. So again, I just want to say, educate yourself, really think about it, get with people, talk with people about it. If you have health professionals or anything like that, please talk to your providers if you're thinking about getting involved. I think that's really important. And I would never encourage you to do anything that you don't trust, but I also, I have the perspective of what this can actually mean without us. So I want us to be involved if possible.
Excellent.
Well, Tyson. I want to jump on something that Tyson highlighted. I think, and some of what Dr. Lee was talking about, I think the response to the virus, the response to the vaccine in the Black community, that is, and in low-income communities in general, is going to depend very significantly on the mode of delivery. And I don't mean the delivery of the vaccine itself, but how you get that into the community. I think if people step in and try to force it on the community, then all of the conspiracy theories will suddenly seem a lot more true. And so I'm hoping that institutions, medical institutions, I'm hoping that public health officials, I'm hoping the mayor, the governor, lieutenant governors and others, county commissioners and others are listening to this. I'm hoping and are thinking of what are some of these community appropriate channels. So think of a number of the groups that currently exist, leaders in these groups. Think of spaces like this one, and Rebalance Life, that can have direct access to the communities and translate, because that's what's going to be needed. The medical community is speaking one language, the community is speaking a different language, and they're saying two different things. The medical community is saying, here, we have this thing for you and we think it's very great for you. We think you should take it. And the community is saying, that's what you told me last time. And look what it did. Why should I trust you this time? And they're like, no, but we're trained and we have degrees. I'm like, yeah, you were trained and you had degrees then too. So what is different? And so what's needed is that core of people in that gap to bridge and to translate across these two communities. So we talk about like providing information. A lot of what was happening in that first round of the COVID virus, when it first hit, was that there was lots of communication, lots of information was being put out there, but it was not being translated over to African Americans in the correct way. And so in that chasm, we know that in nature, any void is automatically filled by something. Nature abhors a void. And it's the same thing with human beings as well. In the absence of information, false information is going to fill into it. And so it's going to be the responsibility of these organizations to step in and say, hey, Aaron Perry, we know you're doing this thing. We need this work translated. Can you get this out to the people? Check in with these other groups. Can you get this out to the people? provide them the information, because what we can't keep doing, which is what we've been doing for a long time, and I think is one of the underpinnings of white supremacy, this paternalistic aspect of white supremacy, where we have the information, we tell you what to do. We're going to make these decisions for you, as opposed to we're going to provide you with all the relevant information and allow you to make informed decisions. So that's what has to happen. But first, we have to get that information to the community.
Excellent, excellent. And I know that Dr. Edwards, when I first met Dr. Edwards, just so much is tied to the mental health and well-being as we've selected this to champion. And I remember Dr. Edwards was the first to kind of really bring this to light, and which is why I'm always happy to have him on board with us. But Dr. Edwards, when we talk about just, getting people comfortable, we're not there yet. We're still months away. But what are some of the things that we can do now to kind of prepare people, particularly if you're feeling that you just don't trust and you can't seem to just get past that? Is there anything that you can offer?
Yeah, there's a handful of things. I think we've spoken to some of those, but I think number one is really to being honest and validating some of those concerns and some of those paranoias. And speaking for myself, I'm one of those people. I'm glad that Dr. Thomas punted that to Dr. Lee instead of me, because I'm one of those people that's reluctant.
Another punt?
Am I going to get this thing when it comes out? I might sit back and let everybody else be the guinea pigs and just kind of see what happens. But I can tell you what, in the meantime, what I'll do, since there is an information void that can't be translated, I always tell people to do that information seeking yourself. And I really mean information seeking, not just looking at the headline and then making up your mind and moving on, or not just watching a conservative news source and then taking that for what it is and then moving on without listening to the more liberal news source or the more moderate news source too. For myself, in the meantime, I'm going to do a lot of what Tyson is suggesting, and I'm going to educate myself, and I'm going to read everything there is to read, and I'm going to get all of the human experiences and human stories attached to the vaccine and to the medical condition at hand. I'm going to be listening to the conservative voices, to the liberal voices, to the moderate voices. I'm going to be reading what the CDC says, what the World Health Organization says. I'm going to talk to my dad. I'm going to talk to my sister, who's a nurse. I'm going to talk to people like Dr. Lee and Dr. Thomas and you, Aaron, and I'm going to well inform myself before I make any decision, because I know that I can't trust necessarily that patriarchal system to give me all the information that I need for me and then my community. So that's the first step. I think Tyson hit it right on the head. Educate yourselves and go beyond the headline and go beyond the comfortable news source that people tend to stick to. As uncomfortable it can be to listen to something outside of your belief system or your opinion, listen to it and look at the pros and cons from both sides or all sides, and make up your own mind after you see that list of pros and cons. Come up with your own consensus. I think that's number one. Number two, in terms of going to physicians or going to clinics or doctor's offices, have a list of questions already written down. All the concerns and all of the questions that you have, don't try and keep them in your head or try to keep them just in your memory to say, I'm going to remember all of these once I go in, because I can tell you it's different once you show up and you're face to face with somebody, especially if that somebody is someone who does not look like you, or somebody who maybe you don't vibe with or don't already trust for one reason. You can be as confident and have all the questions ready to go at home, and then show up and then just become a deer in headlights and forget everything. And then you're losing the ability to gain that information and empower yourself with making the right decision. So write every single question and concern down that you have first, talk about it with people first, and then go in for that visit and say that I'm here to talk about it and ask questions. If I get the right answers, then next time I'll come back and maybe get this vaccine. I think that some of those things are ways to get power back into your own decision-making process when we know that we're not going to get all of that power or that information from other sources, or at least if we just don't trust it. Hopefully you can trust your own judgment and your own experience of reality through taking some of those steps. And then lastly, I would say, think about going with a group of people. If that's something that's allowed, get a group of confident and supportive people that say, I'm uncomfortable like you, I mistrust the system and the vaccine like you. There's 5 or 6 of us. Let's all show up together, ask our questions together. And if you're willing to go through it, I'll go through it because I trust you and respect you. If I'm willing to go through it, you're going to go through it because you trust and respect me. And we're all in this together then. After we've done our information seeking and question asking, get a group to go with you and have that social support with you in that process.
So Aaron, I want to jump in here on this point because I think Dr. Edwards laid out some really good specific pieces of advice that I think can be used, but I want to further Julienne, hint, hint, some of my cooking terminology. So I want to further Julienne that because I think that there are layers to how that applies. So for example, I know for a fact, Dr. Edwards, Dr. Lee, Tyson, we can, and Aaron, we can definitely pick up a research article and digest it and get pieces from it. We can pick up a news article, we can pick up multiple news articles and read across them and come up with the substantive piece that's at the core of all 3 of them. There's a certain amount of privilege that comes with that. I can do that because I have one job. I can do that because I can cut off time. There are just so many privileges that come with being able to do that. But there are people who, for a number of different reasons, just can't. And so I want to speak for them at this point and to take that and apply it to them. And I think that is where the community groups come in. So a lot like what we're doing on this platform, trying to make discussions around mental health and emotional health of Black men a very common conversation, an obvious thing, a very off-the-cuff thing that happens really easily. I think we need to, as soon as possible, start having discussions at the community level, having discussions with these specific community groups around vaccines. So providing concrete information, taking the news and taking the articles and digesting it, cutting it down, dicing it, and bringing it back down to the people, the lay people, so they can ask questions without having to worry about understanding p-values and pipettes and all of the technical jargon that goes into some of the stuff. How do we take that now? Because often people just kind of blank out once you start talking about, oh, and we did this double-blind study. What? There were blind people involved in this study? Like, we say these things because that's how we talk. And that's part of that translating. So we need groups like this. We need groups in the community to say, we want to prepare you to have those conversations. We talk about going in and having a conversation with your medical doctor. People often don't feel empowered to have that conversation because they don't know what to say after their first question has been answered. When I say, doc, should I take the vaccine? And the doc says, well, blah, 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 blah. I have nothing else to say after that because that's as far as I went in my mind when I prepared for it. So sitting in the community and asking these very specific questions to your community leaders and to each other and hearing them answered and trying to engage that discussion sets you up to be able to go now before the doc and say, well, I heard blah, blah, blah. What do you say to that? Oh, is that what you're saying? Okay, and what about this thing? So it gives you a little bit more empowerment, but also provides you with information that's digestible and useful. To try to make sure that we translate that. And I'm going to keep pointing that our public health officials and leaders need to start thinking about how to engage groups like this one and others in the community to prepare, because it's going to be needed, to prepare for a public health onslaught on the coronavirus when that vaccine comes around. And we can't prepare for it the week that the vaccine comes out. We should be preparing for it last month.
Yep.
We should have been preparing for vaccines and talk about vaccines from last month, so that when the vaccine finally does come out, there is enough credible and true information to dispel any myth. But we're continuing to lose that battle because we remain quiet and we're not engaging the community.
Yes. Well, Dr. Thomas, if I can add to that too, that's, you're really reminding me of being prepared and practiced before you get into that situation. Yep. And it reminds me of job interview trainings. A lot of people are wise in sitting down and having like a mock interview or a role play interview of all the possible questions and responses that could pop up during this interview. And it's very similar just in a healthcare standpoint. We're going to role play or go through a mock conversation with you and a doctor about a vaccine. If the doctor says, yes, absolutely get it. I've given it to my kids. Yep. So I think you should give it to you and your kids. Then what do you say? Then what do you kind of ask back after that? If they say, no, I don't think you should get it. Then what do you say back? Then what do you ask? Going through all of those well before this happens is going to once again give you the power to make your own informed decisions and what's best for you, your family, and your community. And putting the doctor on the spot, putting people like Dr. Lee on the spot. I think good doctors like Dr. Lee,
they love it.
They probably welcome being put on the spot. Yep. Ask me the tough questions. I want you to maybe challenge why I'm telling you yes or why I'm telling you no. And ask me, where am I getting my source information from? How are you so confident? Why are you so confident to give it to your kids? And why do you think that translates to my kids and my family? I would think good doctors like Dr. Lee would probably appreciate that. And that's a way to strengthen that relationship and that bond between you and your healthcare provider that way too. If you're willing to take the hard questions and give the right answers in a respectful way that makes sense, that bond and that trust is even more strengthened. And they're going to keep coming back to you with more questions and feel more vulnerable to ask you more concerns that they have. So I just think that's spot on, Dr. Thomas, being not only well-informed, but well practiced before you sit down in that office and have that conversation.
Right.
Black churches, I'm looking at you. Black churches, I'm looking at you. You have a role to play in this.
Yes, absolutely. And I can tell you, just sitting here watching our men go out after getting that beautiful grooming service, that haircut, some guys are actually walking out and I can see this Facebook Live on their phones as they're walking out. And so very pleased that they're actually tuning in. And that goes obviously talking with the barbershop owner and then some of the barbers and encouraging this. But we actually are having men looking at this as they're waiting or getting their haircut. So I just wanted to share that with you guys, because I think you're right. It is important that we continue to have this conversation. I will be sharing this a video with some of our elected officials so that, they have the tendency that when this time comes, they reach out to us too late. We want them to start putting this down now, looking at us as a resource to get that information out. So with that, we have about 13 minutes left. I'm going to let you gentlemen give, take about another 3 minutes each if you want. And, put little final statements together. Or Tyson, I don't know. I know you got to get going soon. I'm looking at the clock for you. If you want to share something, lastly, go right ahead and then we'll work our way around.
Thank you to everyone, to all the viewers. I appreciate the conversation and everything. And I think just the last thing I'm going to say is, when I look at the community, of this conversation, we look at our African-American community, and I just want to plug kind of you, Aaron, and the service that you provide, because as we're talking about this healthcare advocacy, and having a way to speak for yourself and finding others to help. Hopefully, Aaron, I know, has willingly and will accompany folks to their appointments, things like that, if they don't feel comfortable. And having someone that's in tune and aware and alert accompany you, if that's your choice. That's a service that I know that he provides over at Rebalance Life Wellness Association and the Men's Health Education Center. But as we as a community are fighting for this racial injustice and police brutality, because I'd be remiss if I didn't bring that up, I want us to also, when we can, because police brutality, Black Lives Matter, it goes so deep. And you look at the education system, you look at the healthcare systems, you look at and the employment rates, and you look at things like that. You know, I want, as we continue to build momentum and build this up, to continue to start to look at other aspects of where we are receiving this injustice. And, you know, I want us to, you know, rise up about our education and rise up about our healthcare treatment, you know, because health is important, right? We have to be able to live. I always talk to folks about, you know, if the life expectancy in Dane County for an African-American man is like 52 years old, you know, what are you able to leave at 52? You can't reach your retirement age if you did happen to have a pension on the way, and so you can't get the full pension. So you're leaving in every generation, your family's circulating and starting back from ground zero. And so health is important, being able to live healthy and not live under medical expenses because we're living ill. And so taking care of your mental health, taking care of your physical health, things like that are things that we need to continue to keep in scope as we push along this movement. And so I just wanted to say that I'm encouraged by the way that people have stood up, and encouraged by some of the response from some of the larger entities, but you know, we're still waiting to see some real change. And but I just wanted to pass along an encouraging statement to everyone that's out there doing their part, and then ask them to continue to look forward and into different areas where we need that support. And I just named a few.
Excellent. Thank you, Tyson.
I have a few things. One is, like, unfortunately, the whole coronavirus thing has kind of exposed more injustice that people of color have to face all the time, even from like the healthcare side of things. And I know this isn't necessarily geared towards medical providers, but there has been trust broken, and it's on the side of medical providers. And therefore, I feel the responsibility is on medical providers to fix that. And as much as I appreciate and want patients to be proactive when they come and see me and ask good questions and things, I still feel like the responsibility is on me and on the medical community. It's almost unfair to ask someone to come back and without my side carrying the brunt of the weight, because that's what has to happen. And the research is clear that for physicians and medical providers, I mean, amongst other things, it needs time. And we need to take more time with people to build trust. And that's absolutely required. And that means more face-to-face time in every single visit that we have with people. But I think it also will require going out in the community and getting us out of this place that is uncomfortable for people, and getting to the barbershop or getting to churches and being open to answering questions there in order to disseminate information. I think that'd be a much more effective way of doing that. And then, you know, I know we're running out of time, but one question I was interested in having you guys answer is, like, what do we do about the fatigue? Because I foresee this coronavirus thing it's just going to go on. And then our other emotional fatigue on top of everything else with the Floyd incident. I feel like I'm exhausted. I can't imagine how other people feel.
Mm-hmm. You know, one of the things we've been offering, excuse me, so we've kind of adopted Saturdays as our physical health and mental health initiative. So basically, we invite our African-American men, or men in general, to come out on Saturday mornings and take part in a 1 to 6 mile run or walk. Our motto is no one gets left behind. We have been given a generous donation of masks. We still have some left over. So everyone that shows up will be outfitted with their own personal mask. Then after that, we have a tendency of just having a conversation. Any questions that, the best way to put it, I call it our policy walk run. So as we're walking and as we're running, we're talking about these social issues, but we're also paying attention to the people that are coming towards us. We still see, as Black men running, we still see the white female that clutches her arm, and all of a sudden you can see her biceps tightening up as she's coming towards us. And I love saying, "Hi, I'm a former cop." you know and you shouldn't have to do that, but we still see that. We still see today, this morning, typically after we're done, we ask someone in the arboretum to take a photo of our group. We love putting that out there as just an encouragement to the community. And that was a challenge today, but I had to respect that because people were concerned about COVID 19. So I had to respect that. Everything is not always related to something, and that was one of those examples. But we tried to put that out there to encourage people at the bare minimum. Let's get our health stronger. If you have an underlying medical condition, let's get it under control. Do all the things that we have the power to control. The virus is coming. It's here, and there's another wave that we hear that's coming. And so we're just trying to help and encourage our men to get stronger physically, mentally, and emotionally so that we can take on this beast, because it's here.
I'll say, Dr. Jonas, Dr. Lee, for your specific question, Urban Triage has some really interesting resources on there. One of them is, I can't remember if it's called the Pulse or what it is, but essentially has you walk through these different things that you might be feeling to see how much and if it's having an effect on you, and then trying to figure out what to do once you've gotten to that point. So check Urban Triage. They have some really good resources. I'm sure you check the CDC as well. They have some other resources on there as well that kind of help you think about when is it that you've given so much that you're at the point where you're almost feeling depleted, because we don't want you to be depleted. We want you as an excellent physician out there continuing to do the work, but we also want you to be able to take care of yourself. I would say, I think Dr. Lee, you ended it really, really superbly by saying that the work, the brunt of the burden has to be on the system. The system has far more resources than all the people combined, than the entire community combined. I'm not even talking about monetary resources, which is also very important, but has more resources than the community can ever dream of having at this point. And so the system has to take on the responsibility, financial and otherwise, of doing that. When I was a postdoctoral fellow at the University of Michigan's Depression Center, they had this really awesome initiative where we went into Ypsilanti, a neighboring community to Ann Arbor, that's low income, predominantly minority, and took the resources, took the provision of services out of the predominantly white looking setting, and put it directly in the community, in a clinic in the community. So people felt a lot more comfortable coming in and walking into a smaller space. It was also easier for them. They didn't have to schedule bus routes, and they didn't have to schedule rides, didn't have to schedule coming at a particular time. They could come later in the evening when they're between jobs. There were so many things that were automatically taken care of once the policy and practice of the institution shifted to focus on the group rather than on the profit or on the historical practice. And I think that's what's necessary. We need the institutions to make those changes, and the community needs to start stepping up and helping to translate that message to the community.
Thank you for that. Well, we got 2 more minutes. Anybody want to take a jab at that last 2 minutes? I know Tyson is signing off. So thank you, Tyson, for joining us. We appreciate you, man. Well, with that said, again, thank you everyone for joining us and joining this discussion. We're going to continue to offer these to the community. I know that we have people tuning in from a number of places. I got some texts from Racine, Milwaukee, a couple of people in Iowa. We really appreciate that. I know that. Dr. Thomas, I'd like to let you give a shout out to some of your peeps.
All the St. Lucians on here and people from Trinidad and Tobago. We have a few people over from the UK and Ireland. Want to thank you all again for joining in, continue to join in. Lots of friends and family on here. new friends that I'm making, and hopefully will become part of my logical family very soon. But really excited to see all of you here, and hope you continue showing up.
Yes, yeah, this is definitely a movement, and we're really pleased that once again we're offering something special right here from Madison, Wisconsin. I'm very pleased with that. But again, I want to make sure I thank all my panelists. Dr. Jonas Lee, thank you so much. You just consistently step up for us. We really appreciate you. Dr. Logan Edwards, thank you so much. This whole mental health well-being started with you. I think that we're starting to see this sweeping, not just across the state of Wisconsin, but the nation. It began with you. And then Dr. Thomas, just what you bring in support of us, it's just nothing short of amazing. So once again, thank you, everyone. We will be back next week, same bat time, same bat channel. So take care, everyone. I'll talk to you soon.